Well, if you're in the dark about what it is that's causing your pain and limiting your freedom to do the things that you really, really love, it's tough to have a positive mindset. So, for the basics of peripheral artery disease, let's welcome Dr. Paul Michael.
Thanks so much, Kim. What a wonderful introduction and what a great discussion. I love that the talk starts with wellness and not starting with illness. Unfortunately, there were so many great points that we can branch out from there, but just a couple. The spirit of connection, okay, so vital. Maintaining hope, because you guys are absolutely right. The disease does not define the person, and the person is so much more than disease that they're suffering from. One of the issues today that we're facing, and why we're all here together discussing this disease topic, which is so fascinating, which continues to perplex a lot of patients in the system, is that the spectrum of this disease does not have a face. It does not have a true identity. And I'm going to get into that. And not in a medical manner, but more in a mechanical manner. And I want to show you what that is, what the true disease is, where it starts, what it's doing. So I'd like to share my screen here just to share a couple of slides as we move the discussion along. And one of my favorite psychologists, he's actually a child psychologist, but one of the most influential people that ever walked this earth was John Piaget. And he said, what we see changes what we know, and what we know changes what we see. And as human beings, we are observant, creative creatures wired for connection. But a lot of times we don't understand something until we can look at it, until we can see it. And what we're really dealing with here is consequences in a non-judgmental way of survival and adaptation, and what happens when we're maladapted to our environment. So essentially what is going on is we have behaviors that we are responding to. And the response from a medical standpoint has essentially become a reactive healthcare system trying to treat problems instead of acknowledging and preventing the root causes of those problems, which would allow people to start in wellness. And unfortunately, most people that I end up seeing initially start off with illness and end up remaining in that spectrum unless we can do something about it. And even if there's not a physiologic answer to what's going on, David Hoke hit it on the head. The psychosocial acknowledgement and treatment and hope is what allows people to not be defined by their physiologic disease, because we are so much more than just a physical being. But when we are talking in the physiologic realm, we have to have a little bit of fundamental understanding about what is going on. Unfortunately, we can't see what's going on the inside. And the majority of the times in the peripheral artery disease problem that we're facing, we don't acknowledge the problem until we can see it. And why is that an issue? Well, as Piaget stated, what we see changes what we know. So we're here to change what we know so that we don't have to wait until we see the problem to acknowledge it. And I'd like to take you back 4,000 years to my motherland home country, where atherosclerosis was well known about at this time. Well, in the last 70 years, we have tripled the world's population. Why am I bringing all this up and making all these connections? You'll see. So through CAT scan analysis of mummies, we're able to see that atherosclerosis did in fact exist, but not nowhere near the prevalence that it does now. Not only did it exist, they had incredible mechanisms for treatment, which allowed people to maintain their humanity and function without having to amputate entire legs. So the disease burden was not just limited to toes or peripheral little vessels. We're talking about real peripheral artery disease blocking major vessels. But essentially, a lot of our behaviors now inflame the problem. And David also talked about stress and inflammation. And I'd like to talk to you about what that actually looks like on the inside and what the causes are. And here is what the CAT scans look like of the mummies. I did publish an article with the University of Basel in CLI Global discussing that the treatment and the recognizing of this problem and how it was treated with partial amputations truly indeed was the first medical diagnostic evidence of treatment for critical limb ischemia. It wasn't until the let's say 1858, that we had a modern better understanding of the physiology of what this disease did. Remember, I talked to you about behaviors and maladapting to the environment and what accelerates problems in this most incredible machine the universe has ever seen, which is the human body. So, in animals who were dealing with issues with helminths, which is worms, they started blocking the arteries of horses in the hind legs, and these horses could not walk. And that is where we have the word claudication comes from. Many of you have heard this term. It's pain when walking, pain that requires you to stop, pain that comes on from not being able to receive the nutrients and the oxygen to meet the metabolic or functional demands of the muscle. By studying the anatomy of these horses, we were able to put together the loop of the pathology and the anatomy, and to start understanding that blocked arteries causes pain in legs, which does not allow an animal or a human to walk, causing problems. And if that horse couldn't work, it had to be put down. If a human cannot walk properly, then he can't think properly, can't work properly, can't function properly. And now we're starting to build a picture of what that actually does to the human. So in the 1920s, we were able to start putting this whole picture together on how we could use the anatomy to treat people who had this problem of peripheral artery disease. And in 1964, we had the birth of angioplasty done in legs to prevent a leg from being amputated. So why almost 100 years later is the explosion of this problem still wreaking havoc on our system? And by understanding that wellness is what we need to be discussing, it involves taking accountability and understanding so we can have responsibility as patients, as people, and not have to depend on a healthcare system that may not understand the individual patient at their level, which is too busy reacting to disease. So, what is p.a.d.? p.a.d., like I said, is blocked arteries. I'd like you to stop thinking about anatomy, medicine, and physiology, and let's make this really simple. I've treated over 5,000 patients with this problem, and there is no difference than fixing air conditioners, plumbing pipes, pools, which are all attached to pumps. And all of these pumps have some kind of filtration mechanism. The same mechanisms that plague these pipes and pumps, causing blocked issues, is the same issues that cause our arteries to not be as healthy as they can be. So essentially, we have problems with flow, we have problems with corrosion, and we have problems with insufficient supply of volume to the destination. What do I mean by that? Corrosion is the enemy of these pipes, the same way that inflammation in the arteries creates atherosclerosis. Oxidation causes rust. The poor flow mechanics and humidification causes mold. Both of these processes lead to the plugging up of pipes. Not only does it plug up the pipes, it makes the pipes harder. So the compliance, or how soft and reactive these vessels are or pipes, becomes decreased. So they become very stiff. And this is exactly what your doctors are trying to explain to you when they talk about risk. Now, what increases this risk? What makes the pipes start to look like this? What is causing the rust? What is causing the mold? What is causing the blockages in these pipes? Well, the broad term of inflammation is correct. So what increases the inflammation? It's things that you can't control. It's the deck of cards that you're dealt with. But what you can control is how you play those cards, how you play your hand at the game. So these are the risk factors that are modifiable, the ones that are in your control that you can change in your hand. And that's what doctors and the health system are trying to help you with. And those are the things like high blood pressure, smoking, high cholesterol, diabetes, obesity, and living a sedentary lifestyle. And just by gaining control and doing those small steps that David was speaking about, you tend to get a better sense of control over your own machine, your own body. So again, not being defined by your disease, but define yourself by the ability to be able to do something about this. And knowledge is power. This is what mold looks like in a pipe. Unfortunately, when this problem is left unchallenged, this is what happens. But we can't see what's going on inside the vessel unless we screen for it. And that screening tool is simple tests that can be done in doctors' offices to have awareness that this problem exists, to empower the patient to be able to do something about this. And now the control is back in the hands of the patient. But if somebody is not screened, unfortunately, this is what happens. The problem is discovered when it's too late. And by the time you have to call a plumber, either the drywall or the cement has to be ripped open. And unfortunately, we cannot go to Home Depot and buy new arteries. Now, there are incredible methods of treatment, like you are aware of. But my point here is to raise awareness for the fact that we are a reactive society and we should be proactive to prevent this problem from happening. Putting the whole picture together, when there's an issue with the pump and the pipe, it leads to wounds in the legs, which is known as critical limb ischemia. And by the time your grass looks like this, you can bet there's probably an issue with the metabolism of that yard, with the flow, and maybe the pump delivering. So this is putting the whole picture together. Now, medically speaking, most people think of peripheral artery disease as a continuum. The issue is, if we don't know what the vessels look like on the inside and we're waiting for a problem to happen on the outside, then an asymptomatic patient, meaning somebody with no symptoms who feels perfectly fine, can present either with leg pain or go straight to a wound. Because unfortunately, when they don't know what the arteries look like inside and they can't feel their feet from something called neuropathy, then they can present as a first presentation as somebody with a wound, having never known that they had blocked arteries, unfortunately. So the spectrum of the disease ends up appearing like cancer. Somebody feels fine one day, has a problem, and all of a sudden they're diagnosed with cancer of the arteries. And that's what I want to leave you with, thinking of critical limb ischemia. It essentially is a cancer of the arteries, which can be prevented. And that's the incredible thing, is that by getting a community together, raising awareness, and keeping it as simple as understanding that reducing cardiovascular inflammation reduces this risk, we put control back into the hands of the patients, where a healthy lifestyle, like David was saying, significantly reduces the risk of this ever happening. Unfortunately, when it's thought of as a continuum and you're asymptomatic, most people wait until it becomes a reactive issue. And I was asked to speak a little bit about the statistics. Yes, the 1-year outcomes and 5-year outcomes of this disease are very poor, and they're worse than the majority of most deadly cancers. Unfortunately, this has to be looked at as a deadly cancer because the 1-year outcomes are that a quarter of these patients are amputated, a quarter of them are dead from cardiovascular mortality, which is the number one cause of death in the country, and only half of these patients are alive with 2 limbs at a year. At 5 years, well, the statistics are much worse. So preventing this means understanding what's going on inside, not being defined by a disease process, waiting for it to happen, taking control and reducing the inflammation by taking that deck of cards in your hands and playing the game the best that you can to live your best life. Thank you so much.
And that's a real live wall that you have in your office, which I've gotten several pictures from our friends who have gone to you, and you've saved their limb. I get the picture of the real life wall that says "Save a limb." It's absolutely fantastic. I do have a few more questions if you have a few moments, to stick around. P.a.d warriors typically have multiple comorbidities, so it's really important to create a team that communicates effectively to ensure planning, treatment, and follow-up. And at that core of choosing the right, primary care physician, that's really key. Someone who understands p.a.d. and can lead the care team of endocrinologists and podiatrists and all of the above. So can you go into a little bit of, how to choose the right primary care physician and who should be involved in your p.a.d care team just overall?
Sure, those are two great questions. So when choosing a primary care physician, you are choosing to engage in a relationship with somebody who you are entrusting to educate you in a responsible manner about what's going on with your health. So understanding that that's the beginning of a relationship, you should come into that experience eyes wide open. You should be able to ask open questions. You should be able to get your time to ask these questions in a reasonable manner and expect that that relationship is built on some accountability that you're also going to be doing your homework to try your best. When when patients have expectations that the physician is going to tell them what to do and everything is going to be okay, then that's not a relationship. So I highly suggest coming with lists of questions where you do your homework prior to going to that visit, so you can empower your physician to be able to give you the information that is now customized and individualized for what you need, and be very open and honest about what you're feeling, what you're experiencing, and understanding your risk. So that relationship turns into education. The education turns into awareness for you. And now you're eyes wide open about what you can actually do to reduce your cardiovascular risk. Unfortunately, the healthcare system has been experiencing a fragmentation of healthcare. And a lot of people on this forum have seen what that's done, essentially health scare. So the primary care physician has to have a holistic approach to be able to look at the person as a whole person, not as a symptom. The importance of that is that when there is an issue that requires specialty care, they can then be the quarterback for your care and appropriately hand off the ball to whoever needs, and I say needs, which is an important word, to be involved. The teams may look completely different, shifting on to the second part across the country. But if you have a plumbing issue in your house and it has some related problems, you may not have to call a mechanical, electrical, plumbing engineer to come and redesign the home. It may just require a good plumber who understands the basics. If it's a big problem in a big place and needs some more detail, yes. Why do I simplify it to that point? Because a lot of programs stress involving 10 to 12 different specialties. Now the patient becomes fragmented with no true quarterback centralizing that care. Some of the best limb salvage programs in this country only involve two people: somebody who understands the plumbing and somebody who understands the carpentry. To be able to heal a wound, do the wound care, or redesign a foot for function and get flow down to the foot is really the essentials. If there's a good primary care involved, then the cardiovascular and the metabolic or the medical issues can be managed. And back to the first talk, reducing inflammation, attacking the diabetes, attacking the cholesterol, attacking the high blood pressure. But about 50% of this, honestly, is attacking the psychosocial stress placed on these patients who now feel isolated, who don't have a sense of self, who are depressed, who are highly anxious. And good luck, try getting therapy through to a patient like that who just can't listen and can't absorb through that mess of being disconnected.
You know, what you're saying is really music to the ears of so many people, because we talk all the time in our network with all of our friends that we don't feel like doctors really understand the psychological impact that this disease has on our p.a.d warriors. I mean, not just in the fact that it's, you know, a small vessel disease, but when you're diagnosed with any chronic illness, that can certainly weigh on you. And the time between getting a test and getting the results of a test can be excruciating. Every single moment you're worried. And then when you do get those results and they're in your app, and then you don't have a consult with your doctor for another month, I mean, it just keeps escalating. So any advice for some of our p.a.d warriors on how to have a better discussion, even when it comes to the schedulers, to get them in sooner and to kind of reduce this time of worry?
Well, that's a great question. So by understanding what is actually going on and being able to describe your symptoms well, then if you present that to the physician, there is some accountability that you're being able to create currency with. So if you understand the buzzwords and you understand what's going on by being empowered and educated, now you are mandating a response. And if that response is not received, then you're going to have to find a different place to establish a relationship. That's why that initial relationship is so key. Because if somebody is having claudication, okay, that has now progressed to rest pain or a wound, see, there's a fundamental understanding in the cardiovascular world of what chest pain means, of what a heart attack means. But if a patient is having a foot attack, this disease process does not have the identity or the care pathway to be able to process these patients in an efficient manner. So what happens? Patients get frustrated. They wait longer for therapy, and just look at what COVID is doing to all diseases. Screening gets delayed, vital therapy gets delayed, and unfortunately that leads to amputation risk. So understanding that what are the factors we can do to prevent this, and then how to discuss your symptoms with your doctor, that comes with a lot of resource material that organizations like yourselves are presenting to patients, because something has to be done. And if you know you have this disease, you always have the option to go somewhere else where something can be done.
And feel free, you may like and you may trust your doctor, but if they're not the right one for you, you need to move on. And it's
And
it's your life or
a
the money.
patient shouldn't be castigated for wanting a second opinion. But many
Yes.
patients are felt like they're being punished just for bringing the idea up. And
Mhm.
anytime a patient asks me that, I happily give them their records and explain to them and make sure they understand what they should be presenting to empower that other physician. Because maybe somebody else has a different answer. But the majority of the patients that are coming to see me are second or third opinions. And the
Isn't that
patient
crazy?
shouldn't be judged for wanting that.
No, but yeah, there are quite a few that I know that are on here right now that have told me that their doctors have refused second opinions. They have been intimidated, and at that point, that is a red flag. If someone's refusing a second opinion, then you definitely need a second opinion, right?
I mean, it's back to that issue of connection, right? So
Mhm.
when you're seeing those signs and symptoms, it's essentially you're diagnosing a lack of connection within the system to be able to provide care to patients.
One thing you brought up earlier that's still just, haunting me just a little bit is just when you're talking about the fact that it's like cancer where one day you seem fine and the next day suddenly you're hit with major symptoms. And we have our friend Donna on here that was suddenly with this acute attack on the legs. It's just like having a heart attack is how she described it, except, in the legs. So many times we talk about the fact that many doctors wait too long to diagnose someone who's at risk for a heart attack. And we're finding that same problem, with the legs. And so many doctors are saying, hey, I'm not going to do anything for you until you experience lifestyle limiting claudication. But for some people, especially in women, they don't present until they're in advanced stages. So how can we change this paradigm, and how can patients help in this process to educate their physicians and get them to act sooner so that we are not waiting until these patients have tissue loss where they're a toe stub away from amputation before we act?
That's a great question. So that's why it's called the art of medicine. It's not a perfect science, and don't let anybody make you believe that it is. So putting patients into guidelines or treatment algorithms or boxes excludes the individual who may be presenting with atypical symptoms. So waiting for a specific complaint on a piece of paper or a guideline to fit a patient may unfortunately create a situation of underutilization of appropriate resources, or basically not being able to use good tools to get a person back to healthy living. So we cannot look at a person just as a set of symptoms. We also have to see, what do those symptoms mean to that person. So if a person is being impaired from being able to do what they want, or the total amount of days of their life is being impaired by something that they're complaining of, that has to be looked into. So how do you empower patients? Well, they should understand what the basic disease process is. Instead of waiting for a doctor to tell them you don't have this, why shouldn't a patient not know what they could have by living a certain way or having certain risk factors? So the education has to come not just from the doctors, not just from awareness groups, but it starts in school. For instance, the number one cause of blindness, dialysis, and amputation in this country is diabetes. So why shouldn't kids know that? So it's tough to hold all the accountability on the system. You cannot hold it all on the patient, but as a community, right, that's connected, that raises awareness. I mean, for God's sakes, look at the labels that we put on everything. But why don't kids know that processed sugar can lead them to be hooked up onto a machine to filter their kidneys, can cause heart attacks, strokes, and death? So it requires behavioral change at a community level where we're looking out for the interests of one another to not just create wellness for ourselves, but a healthy society. And so back to the worms and the horses. Many of those horses would not have had these issues if they were not in constrained quarters. Much of the p.a.d. that we discovered 100 years after that would not have happened if we didn't find the link between sexually transmitted disease and advanced neuroarthropathies. So the link between syphilis and p.a.d. was really one of the major reasons why we were able to understand p.a.d. better, because patients started losing the ability to feel their legs. It led to aneurysms. And then doctors like Jean-Martin Charcot in France realized that syphilis played a huge part. So the next behavioral change in evolutionary medicine is metabolic, which is related to the inflammation, which was really related to a Western lifestyle of how we live. So we're dealing with the consequences of behavior. And we have to take accountability for that in a good way and not be defined by the disease if we're diagnosed by it, but by the ability to do something about it. And, Viktor Frankl says any man with a why can tolerate any what. So
That's
with
that.
purpose, and it gives us purpose and meaning to be able to take control of our lives and do it together.
That's amazing. Yeah, fantastic quote. And I'd like to finish. I know it scared a few people when you were talking about the mortality rate for p.a.d. warriors. It's possible to live a long life with p.a.d. Would you talk about, because I scared a few people, I'm sure, how to thrive with p.a.d. So that, with the new technologies and techniques, that's why we talk about it. It's so important to find the right doctor.
Yeah, if somebody's facing limb-threatening situations, then they should be seen by somebody who deals with limb-threatening situations. No different than a mechanic or a plumber. Okay, that's basic common sense. So unfortunately, common sense is not allowed to enter the conversation because of all the variables that we were discussing, bias. But absolutely, if somebody is facing amputation, then they need to find themselves a amputation prevention specialist, period. That's the way it works. And then the other thing to make sure patients should understand is maybe the focus shouldn't be adding days to our lives, but adding more life to our days. And that really gets us to understanding that there's more to this than just a physiological problem. We have to be able to address the psychological component to living in a society where we are dealing with more chronic diseases and how that affects our mental stress.
Thank you so much. Any final thoughts? We really appreciate all of your time, Dr. Michael.
I think the more awareness and the more time you guys spend helping each other, it really makes an impact in the community. And I'd like to share just a non-specific personal story, but the ability for patients to reach out through an organization that listens to them and connects them to the right place around the country where they can get appropriate therapy is huge. And I commend you all for that. And that's why I like speaking with you and sharing my time with you. And I benefit from listening to you because it continues to put a face to this real problem that is misunderstood and requires more understanding to be able to define, put a face to it, so we can prevent this down the road together. And my hope is that I'll never have to do this in the future. But the only way that happens is if we take responsibility and help each other out. Thank you so much.
I love that. Let's put Dr. Michael and everyone else out of work. Really appreciate you. Coming up at 3:30 this afternoon Eastern time, all of our p.a.d. warriors who are on here today are going to be sharing their stories and speaking out and offering lessons that they hope that doctors would learn and maybe don't know about the p.a.d. experience. And your colleague, Dr. Fadi Saab, will be here as well. So if you wanted to come back and join us, we'd love to have you.
Thank you so much.
Thank you.